want to welcome everyone to another live from Cleveland Clinic, updates in digestive disease. And today's topic is advances in intestinal anastomoses. So I really want to thank everyone for registering and for logging on. We have nearly 1,200 healthcare providers that are registered to today's event from over 100 countries. We appreciate everyone logging on. Also those who haven't logged on yet. We know that a lot of this will be viewed after. We're really looking forward for this to be interactive. Please feel free to chime in the chat, ask questions. This makes it so much better the more interaction we have. Before moving on, I would really like to thank our sponsors, educational grants made possible by Cook Medical, Janssen Biotech, Medtronic, and Olympus. So really want to thank our sponsors for making these events possible. So again, going back to the topic for today, it's about intestinal anastomoses. You know, us as surgeons, and probably the thing that kind of, as colorectal surgeons, especially what tightens our sphincters, are the intestinal anastomoses when we create them intraoperatively. It's the things we think about a lot for our patients. And that's why I'm really excited about the panel we have here this evening, which is not only experts about different novel anastomoses that we'll be hearing about, but also all really, really talented surgeons, surgeons that I in a heartbeat would want to have them with me in the OR whenever constructing a complex anastomosis. So really proud to have that. And speaking of experts in the OR, I'm going to turn it over to my partner, Dr. Emery Gorgon, who I've had the privilege of admiring his talent in the OR for almost 20 years now. And, one of the most talented surgeons I've ever seen. So I'll pass it on to Emery to take it away.
Great. Thank you very much, David. Thank you for this kind introduction and your extremely kind words. Welcome, everybody. This is more than 100 countries, and this is such an international webinar, and I'm privileged to be moderating with my partner, Dr. Liska here. And it is a very interesting and really loaded agenda today. Indeed, the way how we are performing surgeries in the last decade has changed dramatically, whether it's intracorporeal anastomosis or CONA-S, resection of the mesentery for Crohn's disease, or single staple transanal anastomosis. This is all new, fairly new, but we are very excited and privileged to be able to hear all about those techniques tonight. And we have really top-notch faculty. We had new recruits with our chairman, Dr. Liska. We got Dr. Hani Chang and Anthony DeBuck recently joined us, and we are very excited to hear from them as well. But first, before further ado, I'm going to introduce you to Dr. Thomas Garofalo, who is leading our East Side Colorectal group, and he is also one of our senior surgeons, and he has done a ton of intracorporeal anastomosis, especially using the robot lately, and I'm looking forward to hearing from him his technique and trips and pitfalls of intracorporeal anastomosis. So he'll be giving us a talk on optimizing intracorporeal anastomosis, techniques, configuration, and outcomes. Tom, stage is yours.
Thank you, Emery. So briefly, I started changing over to robotic surgery in 2021. And probably within 3 to 4 months of starting that, I immediately switched to doing intracorporeal anastomosis rather than extracorporealizing them, because I felt that the overall utility was better and less mobilization was needed. So quickly, I'm going to I have no disclosures, jump into a common one we do, and that's the sigmoid anastomosis, the colorectal. This patient was actually a patient who previously had a Hartmann's procedure for perforated diverticulitis. I've already mobilized the previous colostomy and just stapled it off, dropped it back in, mobilized my stump already, and was getting ready to do the anastomosis. So I'm going to stop intermittently with this video to point out some things. So starting with this is the proximal side. I've already excised the staple line. and I'm preparing it. There was quite a bit of scarring from her previous surgery. And what I've done here, what I did there, was basically confirming what the perfusion was like. Normally I do an ICG test. However, this actually had good blood supply. As I was taking a lot of the scar tissue off, you could see blood at the bottom part of the ring there, and that confirmed my perfusion. When I do these surgeries, I usually start with a cut down in the right lower quadrant, and I place a gel port device with my 12 millimeter cannula through that. I do this for two reasons. I usually have my assistant at the bedside dropping in the anvil for the stapler. It makes it much easier for them, and also it serves as my extraction point, so I usually do the cut down. And you can see that being dropped in. I do a traditional purse string suture in and out. I could make this faster by taking one bite, but I'm letting my fellow do some of this sewing. I'm gonna jump a bit after this next stitch, and here I am putting the anvil in. I'll stop briefly there. This can be tricky sometimes. As you can see, I use my tip up to hold the upper part of the colon. I use the bipolar to pose countertraction, which opens that lumen up very nicely to insert the stapler. I usually try to use a 31 CDH or EEA, depending on which company you're using. I try to use the largest stapler because it just makes for a nicer anastomosis. And here I am securing the purse string. You can see we pull it through. I use 3/0 Vicryl. I don't use the V-lock. I feel 3/0 Vicryl works a little better, a little easier. And now I'm trimming some of the fat off. I think the robot really helps with this, being more exact, and you can see exactly what you need to remove. You can also pick up the diverticuli, and I always reinforce with an endo loop. This is getting the stump ready. Very easy connection. I don't quite move this fast. I will back up if necessary, and you can see a very quick ICG test to confirm the perfusion. And that was very quick. And now we do the air leak test. And that's that. Okay. So for the colorectal anastomosis, I've done about 190, maybe closer to 200 at this point. A few of the tips, I always confirm perfusion with an ICG, both on the proximal and distal. What I like to do to minimize how many times we have to do that is I usually divide my blood supply both proximally and distally. And before dividing with the stapler, I usually confirm that. Shoot a dose of ICG, and I can check both proximal and distal lines of resection at one time. Again, I use a traditional purse string with 3/0 Vicryl. I think it just handles easier. The V-lock suture is nice. However, it's a little harder to handle, and it tends to break, especially if the resident or fellow that you're working with is a little rough. Again, the largest size stapler possible, trim the fat, and I always reinforce with the endo loop just to be sure. Unfortunately, I did not have a very good video for a low anterior anastomosis, but I always use the side to end technique for that. Anything below the peritoneal reflection, or if there's a disparity in the diameter. I usually make an enterotomy 5 to 6 centimeters from my proximal staple line. And if I'm doing a cancer surgery, I usually divide the proximal line of resection with the stapler. I make the enterotomy, and then I make a second enterotomy at the staple line, insert the anvil through that, and then use another firing of the robotic stapler to close the bowel. Again, I reinforce with a purse string suture right at the base of the anvil, just to make sure there's no spillage. Moving on to an ileocolic. I'm going to fast forward a little bit to the good parts of this. This surgery was done for cancer, and there was some involvement of the duodenum, which needed to be repaired. And that's all being done there. Now, a few points here. Minimal mobilization of the transverse colon. I think that really helps with recovery of function. There's a lot of play in the transverse colon, which allows you to manipulate it. So I really don't do a lot of mobilization, except maybe detaching the omentum if it's in the way. When I divide the colon, I make sure I divide it in a transverse fashion. Again, with minimal mobilization, it's hard to get the stapler in any other position. Also, similar to my left-sided anastomosis, when I do a right side, I do a cut down with a gel port device in the left upper quadrant. That allows the stapler to come in, directly in a straight line to create the anastomosis, and again, minimal manipulation of the bowel. This is dividing the colon, again, transversely. The small bowel you can divide in a mesenteric to antimesenteric direction. Here we have a stay suture being placed, and again, confirmation of the perfusion. I always do mine in an isoperistaltic fashion. As you can see, the stapler is in a straight line. And closure of the common channel, again, using vicryl suture, starting at the bottom of the common channel and sewing to the top. Because if you do the other direction, it's a very good chance you may leave a gap at the bottom. It's very hard to visualize. I always do this in 2 layers, and again, using 3/0 vicryl. For the ileocolic anastomosis, I've done approximately 100 cases of this. Again, the stapler ports in the left upper quadrant, minimal mobilization, confirm your perfusion. I prefer the isoperistaltic orientation, and common enterotomy closure is always from bottom to top. And that's where I'll stop.
Thank you, Tom. Great presentation. We have a few minutes. I know we're going to take the questions at the end, but at the Q&A. But I think since we have a few minutes, while it's fresh, I can read from the chat messaging. How long is your 3/0 vicryl? Is a question which I think it's a very fair question.
Yeah, actually for both, I use a 9-inch long, about 15 centimeters, depending on which system you're using. The reason for that is it gives you plenty of play. If you make a mistake, you can always kind of recover from that. If you use shorter, you have to be very efficient. Because I have residents and fellows, I tend to use a longer length.
What do you see the advantage of doing intracorporeal anastomosis? Because you still have to do an incision to exteriorize the specimen. So what's the benefit really in your mind?
So to be frankly honest for myself, I was never very good at straight stick laparoscopic suturing. I can do it. It's going to take a lot longer. I think in the amount of time that you need using the robot intracorporeally, I can usually do a sigmoid anastomosis, give or take about 7 to 8 minutes from the time I start sewing to the time I put the handle in and put it together. We timed it a few times just to see what the efficiency was. Likewise for the right colon, it goes very quickly. I think because of the fact that you have minimal mobilization, particularly for the right colon, you do get faster recovery. In my own personal experience, I've seen about a day, maybe even up to a day and a half improvement in length of stay with that. And then when I go back and I look at these anastomoses, for whatever reason, even though you wouldn't think it would be the truth, is I think the anastomosis looks a lot cleaner for whatever reason. The anastomotic lines seem a lot smoother. The lumen is a lot more patent.
Great, thank you. We'll more discuss about this topic in the Q&A session. Please, if you guys have any further questions, put in the chat box. Especially, I want to ask about nose, natural orifice specimen extraction, and if you have any experience, but we will get to that when we get to the QA session. Now we're going to move on to the second topic, which is extremely also interesting, and our new hire, Dr. Anthony Dubuc, who came us from Canada, who is a European trained surgeon originally, and he's our new section head for inflammatory bowel disease, and and he's a visiting associate professor of surgery at the Cleveland Clinic Lerner College of Medicine and Case Western. So he'll be talking us and giving us a lecture on Hand-sewn anti-mesenteric, the Corona S technique in colorectal surgery, especially for the treatment of Crohn's disease. And I'm very excited to hear this talk. Anthony?
Thank you, Emery, and thank you for giving me the opportunity to talk about this. So as you said, I'm going to talk about the Corona S technique. I have, these are my disclosures, which are not really related to this topic. And what I want to say first is that surgeons always have been very interested in looking how we can impact the complex disease biology with our anastomosis. And so basically the reason why we've been looking at that is that we understood very early on that disease recurrence in Crohn's disease is always related somehow with the anastomosis. First of all, it occurs just proximal to the anastomosis. It usually doesn't occur as much with patients with an endoleostomy, although it can, but it's not as frequent. And if you have a diverted anastomosis, there's no disease recurrence. And so there's definitely something going on with anastomosis that has an impact on disease recurrence. And so we've been looking at whether the diameter of the anastomosis we're making has an impact on disease recurrence, whether we do an end-to-end or a side-to-side, which has a larger diameter, although disease recurrence is usually occurring just proximal to the anastomosis, and it shouldn't have an impact. Also, the impact of the anastomosis on the peristalsis, to see if whatever anastomosis we make has an impact on the transit time of stool, because when you have fecal stasis, it actually impacts the microbiome in the bowel, which we know has an impact through its interaction with mucosa and mucosal barrier and the immunological response of the host on disease recurrence. And then we also have this history of the mesentery and see how that actually impacts the disease recurrence. So again, surgeons are very interested in knowing what exactly is happening with the anastomosis. And more than 15 years ago, there was the first randomized trial to look whether stapled or hand-sewn anastomosis had a different or an impact on disease recurrence in patients. This is the CAST trial that was published in 2009. And basically, what we saw is that at 12 months follow-up with endoscopy, there was no significant difference in disease recurrence. So whether you did a stapled anastomosis or a hand-sewn, it had no impact both on the endoscopic recurrence, which was the primary outcome of this trial, or the clinical recurrence at 12 months as well. So within the same time frame, from 2003 on, Dr. Kono developed the Kono S anastomosis in Japan. And the reason why he thought this was an interesting anastomosis is that he designed it in a way to kind of deal with the problems that we thought were present in the anastomotic techniques that we were using until now. And so the main thing he changed with the anastomosis is the stent, is the support column actually. And so stapling off the bowel, suturing those staple ends together, gives some support to the anastomosis in order not to distort it within the abdominal cavity. And so he thought that in that way, it would actually help the fecal stream to occur more easily than in other anastomosis. The other thing also is to make the anastomosis wide enough. So he prescribes an enterotomy of 7 centimeters away from the mesentery to have a wide opening in the Kono S anastomosis. And interestingly enough, he actually prescribed to have like a closed bowel dissection, leaving all this thickened mesentery behind in order to preserve the blood supply and the innervation of the Kono S anastomosis. And so like the first retrospective, or I would say prospective series were quite encouraging in the sense that he reported reduced endoscopic recurrence. That's actually the first series that was published, reduced endoscopic recurrence, expressed here as a median Rutgers score at 1, 2, 3, 4, and 5 years, reaching significance at 5 years. And also the surgical recurrence was significantly reduced with Kono S anastomosis compared to the conventional anastomosis, which was actually a mix of stapled and hand-sewn anastomosis. Another series showing the same outcome with surgical recurrence at 5 years, with a 5% in Kono S and almost 20% in end-to-end hand-sewn anastomosis a few years later. So we had to wait to the first trial, the Supreme trial, randomizing patients between the side-to-side stapled anastomosis and the Kono S anastomosis, which happened in Naples in Italy. And they randomized 79% with a primary outcome of endoscopic recurrence of using the Rutgers score, including the I2 score, which I'll talk about in a bit, at 6 months, and they had several secondary outcomes as well, including the endoscopic recurrence at 18 months. And so, again, very spectacular results. When you look on the left side, you have the endoscopic recurrence at 6 months And you see there's this very significant difference with pretty high odds ratio, despite a pretty small sample size in patients included in this trial. When you look 12 months later, so at 18 months time point, you see that the same kind of difference is visible. It's interesting also to see that the numbers are actually very similar at 6 or at 18 months. So there is a little bit of word of caution with this trial. First of all, there was no standardized post-operative treatment protocol in patients included in this trial. They prescribed them to have like 1 month of antibiotics after surgery, but there was no real protocolized way of giving any advanced prophylactic therapy in patients with Crohn's disease. There was no central reading of the endoscopic assessment, and we know that that is obviously prone to bias, a very important point. And I'm coming back to the Rutgers score. They didn't use the modified Rutgers score, and so including the I2A as a positive endoscopic recurrence, which favors the CONO-S significantly. And I'll come back to that because in this very interesting study, they looked at the impact of staple lines on ulcerations in the anastomosis. And when you look at a side-to-side stapled anastomosis, you see that some of the staple lines are inverted into the luminal side, and that's the green circle you see there, which is the common channel, and other staple lines are everted outside of the bowel lumen. And that has an impact on the healing, because when you look at this picture, when you see the green circle, you see the inverted staple lines, and this is at 6 months. You see that it by definition creates erosions, while the everted staple line, which is the green circle, you don't see any erosion there. And that's basically because you have the cut edge of the bowel facing into the luminal side of the bowel. And so this study looked at all the video endoscopies performed at 6 months in the DETECT trial. The DETECT trial was designed to look at the impact of vitamin D on Crohn's disease recurrence at 6 months. And they used that database of endoscopies in patients to review everything and see whether there was any difference in healing in staple lines. And interestingly, and looking on the right side of this table, 3/4 of the patients with Crohn's disease had ulcerations on the inverted staple line, while almost nobody had any ulcerations on the everted staple lines. They also included a few cancer patients, obviously from another database, and they also saw that was like a very, very small number though, but also a pretty significant proportion of those patients with staple ulcerations on the inverted staple lines. And when you look at the Crohn's patients, 1/4 of the patients had no ulcerations in the neoterminal ileum. And so just to show that having ulcerations on the staple line doesn't mean you have Crohn's recurrence. And when we look at the SUPREME trial again, including patients with I2A recurrence is not fair for the stapled anastomosis. So again, it's always very difficult to do randomized trials in surgical techniques, and this international randomized control trial of CONO-S versus stable anastomosis was initiated actually many years ago. It's still running, and it's been led by Dr. Michelassi in New York, and they included with multiple centers in North America and in Europe patients with a primary resection for Crohn's disease and randomized between CONO-S and stapled anastomosis. The primary outcome is actually at 10 years with surgical outcome as the primary outcome. It's a very long time. However, the preliminary results were presented at 6 months at ECHO this year in Europe, or more recently now for the 1 to 18 months time point at the ESCP meeting in Paris. And without going into details, was no significant difference in endoscopic recurrence between both groups. You see that we're not there yet in terms of sample size. The total sample size, I think, is more than 500, but it's a pretty significant number. It's actually more than the SUPREME trial. So there was no difference, as I mentioned. And my next slide is actually talking a little bit on how to situate all those findings within the new, I would say, era of the type of anastomosis, what to do with the mesentery and so on. It's all a little bit confusing and contradictory because the CONO-S is prescribing a closed bowel dissection on purpose, while Dr. Coffey initially discovered that removing the mesentery is actually significantly reducing the disease recurrence. But we also have the fact that when you perform long strictureplasties, which doesn't occur very often, but we do see some degree of healing in those patients despite the fact that we don't resect anything. And so everything is a little bit confusing and very hard to understand what to do. And I think one of the very important trials that will come hopefully quite soon is the MEERKAT trial, which actually mixes up everything. They randomize between cone-OS and side-to-side anastomosis, but also to take into account what to do with the mesentery, whether they spare it or excise it at the same time. So they're basically randomizing into 4 groups, which obviously will be very interesting to look at the results. And just to conclude, I'm going to say that the cone-OS anastomosis was introduced to reduce the postoperative recurrence, which was very hopefully seen in the early series and the first trial. But it seems that the bigger trials, multi-center trials, are not really confirming those findings, even though it's still a little bit too early to say for sure. And probably, even though I strongly believe that the anastomosis has an impact on the disease biology, it's probably not sufficient to really change the disease history in those patients, and that I think making a safe anastomosis is probably more important than trying to make an anastomosis that really changes Crohn's disease. Thank you very much.
Thank you, Anthony. This was excellent, great overview. For the sake of time, we're going to proceed, but one quick question. You talked about surgical recurrence. I understand there's endoscopic recurrence and symptomatic recurrence, but what do you mean exactly for surgical recurrence?
So surgical recurrence is when a patient needs a new surgery, when there is, disease recurrence that strictures again, and there is no other treatment possible than surgery. And the problem with that is, I think, in a trial, it's a very subjective endpoint. And I think the strongest endpoint in those trials is always endoscopic recurrence. I think that when you look at running randomized trial, looking at surgical recurrence, it's obviously of interest for patients and physicians, but I think it's a pretty subjective endpoint to use in a trial. And so I would prefer endoscopic recurrence because it's more objective.
So chronologically, endoscopic recurrence should happen first, followed by symptomatic recurrence, and then surgical recurrence really comes to last.
Exactly. Yeah.
Very, very good. All right. Well, more to come on that discussion and conversation about this really interesting topic. And again, thank you very much. Now we're going to move on to another emerging anastomotic technique. We hear this a lot from Italy, from Europe, with single stapled anastomotic techniques after low anterior resections and low cholanal anastomosis, especially from Dr. Spinelli's group. TTSS versus double stapled emerging advances in rectal anastomotic technique. This will be delivered by our also new partner, Dr. Hani Chung, who joined us from Johns Hopkins recently, and we are extremely pleased to have her on our board. So Hani, thank you very much.
Thanks so much, Dr. Gorgan, and good evening. I'm going to be focusing now on rectal anastomoses. So specifically, I'd like to discuss the role for TTSS, or transanal transection, single stapled anastomosis in rectal cancer. And of course, we know that the lower the dissection in the pelvis, the more challenges occur during the transection and anastomosis phases of the rectal anastomosis. In the traditional double staple technique, where both the stapling to transect and stapling to anastomose are performed transabdominally, a perpendicular stapling is desirable, but the limitations of the pelvic geometry and size of commercially available stapling devices sometimes introduce an oblique angle on the rectal stump, which then makes coupling the EEA stapler head a challenge. There's also the inevitable intersection between the transverse staple line on the rectum and the circular EEA stapler, which introduces potential weak spots. And lastly, dog ears that result on either side of the transverse staple line are also possible weak points. And all of these have been proposed as mechanisms for higher anastomotic leak rates using the double stapled technique. When TATME came on the scene, different approaches to handling the rectal stump transanally as a bottom-up approach were explored, and recently taking the transanal transection and single stapling steps from the TATME approach has been explored as an alternative to the double staple technique. It involves performing the TME dissection abdominally as usual, but rather than dividing the rectum with a linear stapler from above, the rectum is transected transanally. 2 purse strings are then placed in the rectum, the first one below the tumor to close the specimen. Then the rectum is divided using monopolar cautery. The specimen is retrieved, and then the proctotomy can be used for a hand-sewn coloanal for low anastomoses, or in cases where the proctotomy is higher, it may be closed using a second purse string suture. The proctotomy can then be utilized to secure the EEA stapler mechanism together in one of 3 described ways. This figure shows the first approach, where the anvil for the EEA in the proximal colon is being passed directly through the proctotomy, coupling the stapler, and then securing the purse string prior to firing. This second approach is to place a drain on the EEA stapler post, pass it through the proctotomy, secure the purse string, grasping the drain transabdominally, and then coupling the anvil and firing. And another option is to place a suture at the end of the anvil on the conduit side, which is then grasped through the proctotomy, pulling the anvil through the rectum to secure the purse string onto the anvil, and then coupling the stapler shaft. The TTSS technique seeks to address 2 challenges associated with the double staple technique that we discussed earlier. First, an even proctotomy can be made without the confines of the bony pelvis to limit the ability to do a perpendicular division. And there's no reliance on multiple staple lines. Secondly, the structural weak points created by intersecting staple lines and dog ears are eliminated. There's also the added benefit of being able to directly visualize the distal margin on a tumor, which in the era of TNT, sometimes it's tough to see the subtle scars that might remain. One might ask, well, why not then just do TATME then? Well, there's the obvious avoidance of a bottom-up dissection that comes with its steep learning curve, and for some, the prohibitive concerns about urethral injury, as well as concerns about oncologic outcomes. But there are also specific technical advantages over doing an entire TATME dissection. TTSS alone avoids having to place the first purse string blindly, and thereby avoiding incorporating the prostate, the vagina, or the pelvic floor into that suture line. Proctotomy is made after TME mobilization, which helps to avoid injury to pelvic structures that are adherent to the rectal wall. And after mobilization, the pneumoperitoneum and transillumination from the abdomen helps to visualize the correct level of transection. The mobility of the already dissected rectum allows for better visualization and control placement of the second rectal purse string without the increased risk of blind placement. So as Dr. Gorgon mentioned, Antonio Spinelli's group in Italy published prospectively on the technique. They looked at over 200 consecutive low to mid rectal cancer patients who underwent laparoscopic TME. 127 had double stapled anastomosis, 100 had a TATME approach, and 50 had the TTSS approach. Anastomotic leak rate was 17.5% in double stapled as compared to 6% in TATME and 2% in TTSS. Reintervention rate after anastomotic leak was higher in the double stapled group over TTSS, and that was significant when the 2 groups were directly compared. And then more 90-day complications occurred in the double stapled group versus TTSS. Stoma closure, pathology data, and margin positivity were all, they were not different. The same group did long-term patient-reported outcome studies looking at consecutive patients undergoing stoma closure after TME for rectal cancer with either TTSS or DS approach. The low anterior resection syndrome questionnaire was delivered at 6, 12, and 24 months after stoma closure. 58 patients per cohort were included. and they saw no difference in the LAR score at 6 and 12 months. At 24 months out, they saw a significantly lower median LAR score in the TTSS cohort. Anastomotic height was interestingly noted in the TTSS cohort was significantly lower. So from this, they concluded that although the TTSS cohort had lower anastomoses, functional outcomes were not inferior to the double-stapled cohort. This was a more recent prospective cohort study from France. They looked at 275 rectal cancer patients who underwent double-stapled coloanal versus TTSS. They saw a significant reduction in anastomotic leak in the TTSS group compared to the double-stapled group, with rates of 8.6 versus 20.9%. There were no differences in LARS scores, and so this group also concluded that TTSS has the advantage of reduced anastomotic leak rates over double-stapled technique. There are a couple of other smaller observational studies that I didn't get into here, but basically all confirming that it seems to be a safe and feasible approach. So for key points, it appears to be a safe and feasible alternative to the double staple technique, and it may improve anastomotic leak rates and functional outcomes. I will note that all studies were done in rectal cancer, so whether the advantages of the technique will hold true for other pathology like IBD and diverticular indication remain to be seen. Thanks so much for your attention.
Thank you very much, Dr. Chung. This was excellent, very interesting technique. Just a reminder for all the audience, please type your questions in the chat box. We are responding to them one by one, and I'm taking some of them here as well and verbalizing them, so your questions will be answered. Please, right now is a good time to put them down. Hani, I'd like to ask you, obviously this is a very challenging, technically demanding approach, technically demanding technique. And in the era of robotic surgery, we can go fairly low and do almost intersphincteric dissection from up top. I think you're right, you know, TATME is kind of falling out of favor from many aspects for complications and so forth. And also, we are getting more facile to be able to do dissection all the way down there. Do you think then really this technique still, even with the use of robotics and deep down dissection, a good approach and provides any additional benefits? Obviously, avoids, you know, dog ears, and it sounds like based on the data, anastomotic leak is an advantage. But if you're really able to use the robot and go down and do a good stapling, double stapling anastomosis, would that be still your preferred choice?
Yeah, that you hit the nail on the head, because the handful of times that I've actually used this technique personally have been in rescue situations, either during TATME. I've done that early in my career, so I've used it during those dissections. But when trying to do double staple technique and something happens where the stapler, the transverse staple line busts open, or there's some sort of technical challenge where I can't do a double staple technique. In those cases, just taking off the staple line and doing it this way has worked out. It always is amazing to me how much longer the rectal stump feels from the transanal approach when you're down there. So I've personally adopted this as a rescue technique as opposed to doing this on a routine basis.
That's a good point. For rescue, I would think that I would probably be more comfortable doing a hand-sewn coloanal rather than doing a TTSS. I mean, it depends how much you're really gonna have cuff left to be able to put that purse string transanally. Would you agree with that statement, or not so much?
I would. I think that if you have enough of a rectal cuff, it is actually harder to do a hand-sewn in that setting. And you know, the hand-sewn coloanal just has its own issues with strictures and functional issues long term, as that one French group showed. So I haven't specifically done it in the setting of trying to avoid a hand-sewn, but I think if there's enough of a cuff, then it makes sense. It doesn't add that much more time or technical skill. So I think it's worth considering. It's certainly not as technically high a learning curve as like an entire TME is for the pelvic surgeon.
Yeah, one trick I think is like with the finger, maybe go above a little bit and create that cuff a little bit more mobilized, because it's stuck to the sphincter muscle. At least that's from what I see for people doing it. So you can really mobilize that cuff circumferentially to the point that it really wraps the staple around. Otherwise, it will be stuck to the muscle. Along the same lines, there's a question in the chat box: is there any concern regarding anal sphincter stretch with TTSS contributing to fecal incontinence? You mentioned a little bit to LAR score and functional outcomes, but maybe you can comment of if fecal incontinence was part of that outcome assessment.
Yeah, they didn't specifically look at fecal incontinence, but I imagine that it's no different from using a stapler for any other sort of transanal approaches. Now, you don't want to, as you pointed out, you want to make sure that the cuff clears the sphincter. You don't want to staple the sphincter, because that could lead to real issues with postoperative pain and chronic problems. But other than that, I think the principles of good technique still apply, and making sure that you have enough of a cuff is important.
Great. And then one question, Anthony, for you. This is a great presentation. Of course, we are excited to wait the outcomes from Meerkat. But until then, what is your preferred operation for Crohn's disease? Do you resect the mesentery? Do you do Kono-S? Like, as an expert in this field, we should really follow your footsteps. What should we do when we resect Crohn's, locally advanced Crohn's disease?
Yeah, so the funny part of it is that I've always resected the mesentery in Crohn's disease, and that was even before it became a thing, because that was how I was initially trained, and that's how I thought that was the way to do it. And then it became a topic which is quite interesting. Now, I think that, and with the mesentery, the problem now is that with the SPICY trial, which came out, I think about a year ago, it didn't show any difference in endoscopic recurrence. I think the primary outcome was 6 months. The only difference is that what they didn't do is they didn't resect the ileocolic pedicle. And so that's a point of criticism, that it's not really a high ligation in patients having the mesentery removed. But I mean, again, conflicting evidence again in terms of mesentery. And so I'm not quite sure what we should be doing. I think from a surgical perspective, it's often easier actually to do a high ligation. You have a very thick mesentery close to the bowel, but it thins out the higher you go on the vessel, and that's why I think it's the easiest way to do it. It doesn't necessarily result in you resecting a longer segment, because you have other vessels supplying the ascending colon and the rest of the small bowel. So I usually do a high ligation. I do a mesenterectomy in most of my Crohn's disease. I've never done a lot of Kono-S anastomosis. Again, for a long time, I didn't have a good argument not to do it. Now with those very recent results, I feel better not doing it. But one of the main reasons, there's actually two main reasons why I've never done it often. Is, first of all, it's much longer to make than a stapled anastomosis, and sometimes that is an argument that you have to take into account, but also often it looked like a very large anastomosis. When you do imaging on patients after a Kono-S, they have like a very wide and large anastomosis, and that concerned me a little bit. And so my preference is to do an isoperistaltic stapled anastomosis side to side. The reason I'm doing that is just for the ease of surveillance after surgery, because the portion of the anastomosis that you have to look at in Crohn's disease is the pre-anastomotic neoterminal ileum. And it's very difficult. It's often difficult to see in a patient with an anisoperistaltic anastomosis. It's much easier to survey when you do an isoperistaltic anastomosis.
What's your technique on isoperistaltic anastomosis? It's easy side to side. You just cut the staple lines and then put it, parallel. But do you do the, like Dr. Garofalo showed, do you hand-sew the common enterotomy site then?
I used to hand-sew it, but now I'm stapling it off. Now when I'm doing it intracorporally, I saw it. I use V-lock. When I extract it through the abdominal wall, I staple it off with a TA60. very important when you do that is to do it exactly as we saw in the first presentation, where you do the colotomy more distally and the enterotomy at the distal end of the small bowel, because you don't want to narrow the proximal small bowel, because that's where the disease is going to recur. And so the lumen you have, you don't want to make it even narrower by closing the enterotomy. So you do it from the distal side. That's where you bring in the stapler for the common channel.
Yeah, and then there are some questions about why high ligation, and that also sometimes make me nervous, because if, as you know, Crohn's mesentery is really a beast. And when you really lose control, I'm always nervous when I get higher, because that's close to the SMA, and it can really create a big hematoma that can lead to ischemia in the bowel as well. Does that make you nervous as well, or you have different techniques to avoid that?
No, it definitely makes me nervous, but I would say the way I try to avoid that is to dissect the ileocolic pedicle. And so I try to isolate it. I try to clip it. It's possible in most cases. Obviously, you have those cases where you have a very thickened mesentery up to very high up. That's a different situation. I think you have to be pragmatic, and you have to pick your level to make it safe. But in many, many cases, it's possible to dissect the ileocolic vessel and to clip it so that you have a very good control of those vessels. Because obviously, if they bleed and they retract, it's a big problem for sure.
Okay, we'll leave you alone, but there's one more question in the chat box. Is the Cona-S anastomosis a feasible option in patients with penetrating or fistulizing Crohn's disease, or do you consider it more suitable for stricturing phenotypes?
No,
So does the disease behavior influence your choice?
No, not really. And when you look at most of the studies, they were actually including any phenotype of the disease. And so even with penetrating disease, it's possible. It's possible for a small bowel anastomosis. It's possible for an ileocolic anastomosis. It even has been done for a colonic anastomosis as well.
Great, excellent. Thank you very much. This was really very enlightening. One question for you, Tom. How about nose? I mentioned that natural orifice specimen extraction. I know with the technique that you showed us with intracorporeal anastomosis, especially on the left side, there are a lot of surgeons also externalize the specimen transrectally by putting a wound protector through the anus. That seems a little bit sometimes to me really tough, especially getting a wound protector all the way transrectally and then opening it up. But then really, if you can externalize the phlegmon or sigmoid transanally, you save yourself a big incision, and I think that might save length of stay as well. Do you have any experience with that, and what are your thoughts about nose?
So I'll offer an opinion. I can't say that I've done one yet. A couple of things. Obviously, I would never do that for neoplastic disease because really the easiest way to do it is you have to excise the mesentery and you have to withdraw the colon itself and then the mesentery through separately. Most patients that I operate on are not going to be able to do it and block extracting it through the rectum. I also have a bit of a fear about doing that, especially in patients with diverticular disease, because they get a lot of scar tissue down there. And you put that wound protector up through the rectum and open it up, and there's a chance you're going to split the rectal cuff, and then you're kind of stuck having to dissect the lower. I have not yet tried it. I really haven't had a patient that I would have felt comfortable doing it in. What I do for all of my patients, like I said, I do that cut down. I put the small gel port device in, and then I always put these specimens in a very large end-to-catch bag and extract it through there. And you would be surprised once you get it in the bag, once you remove the gel port device, it's fairly easy to extract it. A little bit of routine to get it out, as it were, but you can extract it through that. And to this point, I have not had anybody have any complications or hernias in those sites.
And then what site do you use then for that extraction? Is it suprapubic, phenostyle, or more right-sided?
Like I said, for my left-sided resections, I'll make it's about a 4 centimeter cut down in the right lower quadrant. For the right side, I'll put in the left upper quadrant directly over the rectus muscle. I'll do a muscle splitting there.
Okay. Yeah, I do use phenystill as well, which also helps well with the retrieval bag, I think, and I agree with you. With the retrieval bag or INSI, they come with 10, 15 even. You can be surprised how small the incision can be, and you can extrude the specimen. Well, thank you very much. These were great talks. Now we're gonna move on to our case presentations, but for all the faculty, I want them to stay on because I want you to chime in and make comments. And there are a couple of questions in the chat box on rectal cancer, and I think first case will cover that, and hopefully we will get those questions as well when we present the case. So it is my great honor and pleasure to present you to our colleague and partner here, Dr. Michael Goldenschluger. He has joined us a few years ago, and he has been doing a terrific job, especially in the east side now, helping Dr. Graffalo as well. And he'll be presenting us two different cases, but let's see how many we can get to. Let's start with the first one, Michael. Thank you.
Thank you so much, Dr. Gorgon. So the first case is a distal rectal cancer on an obese patient. I will try to focus on the intraoperative challenges of this case. We can move on, Steve. So the first case, go ahead. The first case is a 58-year-old male with a BMI of 41. You can go ahead, Steve. Yeah. With symptoms of fatigue, diarrhea of 9 months, and weight loss, who presented with rectal mass causing obstruction. He actually presented to another hospital. We can move on to the next slide. And we can see here the presentation, the CAT scan that was done in the emergency department, which basically shows a colonic obstruction due to a very distal rectal cancer all the way 2-3 centimeters above the sphincters. It's a bulky tumor, which basically obstructs most of the rectum and the narrow pelvis. Next slide. At this hospital, he underwent a lap loop sigmoid colostomy, and they also performed a flexible sigmoidoscopy and biopsies. Next. They found a circumferential tumor 3 centimeters above the anal verge, and they did an initial biopsy that was inconclusive, but the repeated did show a tubulovenous adenoma with focal invasive adenocarcinoma, and the tumor was MMR proficient. They performed a CT for staging, which showed no metastasis, and the CA was 4.5. The pelvic MRI showed a locally advanced pelvic disease with T4A and plus, but no sphincteric invasion. Next slide. He was presented in the tumor board, and the plan was to go ahead with total neoadjuvant treatment. He started with longer-term chemo radiation and then a consolidation chemotherapy with FOLFOX for 8 cycles. He then presented to our clinic in the Cleveland Clinic 4 weeks after the completion of the total neoadjuvant treatment for surgical evaluation. Next slide. And this is our physical exam in the clinic. We found a large peristomal hernia with a prolapsed loop colostomy. Next. The DRE was a weak tone with firm fixed mass 3 centimeters above the anal verge. The MRI showed an MTRG grade 3 with residual tumor. Next. And you can see here on the left, this is the MRI, which shows a clearly residual tumor after TNT in the distal rectum. And this is the flexig at the level of the sphincters, shows a large residual bulky mass in the distal rectum. Next. So here I wanted to kind of discuss those findings and maybe ask our colleagues, what should be your planned surgical approach, and what should we communicate with the patient about the expected outcomes of those surgeries?
Michael, before you move to this question, I'm going to ask, because there's also in the chat box one question about that. If the patient comes in with large bowel obstruction due to tumor, rectal cancer, what is your preferred choice of diversion? Would you do a loop colostomy or diverting loop ileostomy? We'll listen to from all maybe faculty members. Tom, how would you divert someone coming with obstructing rectal cancer?
I'd probably personally try to do a loop sigmoid. If he's completed TNT in 3 weeks, I'm reading the question now. I would probably still divert him with a loop. using the proximal end for my eventual reanastomosis, but it also kind of depends on exactly how much response they got. Because you could proceed with a low anterior at this point. I don't think I would do a Hartman's, especially with the cancer if it's bulky, because again, you just have to go back into the pelvis.
But DLI or loop would definitely not would be the preferred choice of option here, right?
Yeah, agree.
Dr. Chong, do you agree with that statement?
I agree. The issue with doing a DLI, even though it's technically easy and it can be part of your, eventual proctectomy operation, if the patient has a competent ileocecal valve, you're not really fixing the large bowel obstruction.
Agreed. Yeah, Dr. Dibak?
Yeah, I would say I would prefer loop ileostomy actually, because again, if you really have a very distended bowel and there's a competent ileocecal valve, that's probably a reason why I would not do it. But I would still push for a loop ileostomy. I think that it will not interfere with the surgery afterwards. Like if you do a loop sigmoidostomy, it may be annoying to do like any reconstructive surgery after. I'm not saying it's not possible, but it's more annoying. And you can just leave the ileostomy until after surgery to divert whatever reconstruction you do. That if you consider a reconstruction, I'm not saying that you would. I mean, there's about 3 centimeters of non-involved distal rectum here, so I'm assuming that we could reconstruct this patient.
How would you assess if the valve is competent or not?
So if you look at whether the small bowel is distended, and if the bowel is distended, small bowel is distended, you know that it's incompetent, and that doing a loop ileostomy is probably reasonable. So that's what I would look at.
All right. Dr. Liska, I don't know if you have any comments.
Yeah, no, I agree with what everybody said. I think an ileostomy is definitely easier, and will make the next operation definitely a lot easier because you can just leave it there. But if there's a competent ileocecal valve and the colon is very distended, it's going to be a problem. So I think you have to look at the CAT scan carefully. And if the small bowel is dilated, I think it's reasonable to do an ileostomy. But if the small bowel is completely decompressed and the colon is markedly dilated, it's probably not going to work. And then lost.
And what Dr. Grappolo said, I think is, I agree very much. As distal as possible, right? So you can bring a conduit down. And the other thing is, if you're going to do a colostomy, it's probably you got to pay attention to not to hit the marginal. Stay really close to the large intestine. And if you're going to put a rod right underneath that, is probably the key in that. Okay. Now we have a nearly obstructing cancer that was treated with TNT. Is that right, Dr. Goldenschluger?
Yes, so treated with TNT, residual tumor based on clinical examination and the MRI.
So what is the next choice for treatment or option? Is that the decision we need to make?
Yeah, so and what should be the communication with the patient about the expectation from long-term resection or APR based on our plans?
Dr. Chang? It's an obese patient.
Obese patient who sounds like I thought I saw in your history that the patient has fecal incontinence and on exam, not a lot of tone. So I think that oncologically, it looks like there's space there to get a distal margin. So I think an LAR is technically feasible, but I would counsel the patient about the significant risk of LARs after such a low anastomosis, and have them have a conversation about whether they would just move on to an APR from the get-go.
Are you worried about being someone incontinent after they were diagnosed with rectal cancer, especially with such a locally advanced cancer? Or do you think that incontinence and functional changes are more related to the cancer itself? How do you assess in that case what their baseline continence level is?
Yeah, I guess the most objective way to do it is to get a manometry and just study the sphincter. But I just do like a quick exam in the office where I do a digital rectal exam, have them squeeze, have them push, and just see the how their pelvic floor is in terms of functioning and being able to follow commands. But yeah, I agree that it could be related to sort of that overflow incontinence type of picture with the cancer. The radiation also could do some damage to the sphincters too. So, but I have found that I don't routinely get manometries on patients preoperatively in this setting. I have found that just doing a quick digital exam in the office and kind of talking them through what their symptoms were pre-diagnosis and currently is usually pretty accurate.
So this patient is adamant not to have a colostomy or permanent bag. He's really pushing Dr. Goldenschluger to have a reconstruction. So in that case, Dr. DeBuck, what do you want to do? You're muted, sorry.
Yeah, sorry for that. Yeah, so if the patient is really willing to avoid any stoma, if it's within the safe margins of oncological resection, I think it's reasonable, after having a long discussion with the patient and so on, I think it's reasonable to do a reconstructive surgery. I think, again, I mean, I think that with available technology, we can go as low as we want in the pelvis. And I mean, obviously, probably it's going to be a robotic dissection here in the pelvis to go very low into the pelvis. And I mean, it's going to be tight for stapled anastomosis here, but the great thing about the TTSS is that you can really tailor where you're going to transect the rectum. And so if you feel that you don't have the space, once you've completely mobilized the rectum, you can still switch to a hand-sewn anastomosis. I feel also that once you've mobilized the rectum completely, and that's probably also one of the advantages of the TTSS, once you've mobilized, that distance becomes a little bit better and a little bit longer. And so I wouldn't necessarily commit right away to a hand-sewn anastomosis. I would still try to staple it, leave a little bit of that cuff to be able to do a TTSS after I have dissected. Obviously, if it's not possible, you can still switch gears to a hand-sewn anastomosis.
What's your absolute contraindication for not to do a reconstructive surgery, reconstruction after in rectal cancer patients?
I mean, obviously, if you don't have enough margins and it's invading the sphincters, that's
When you say
obviously
sphincters, which sphincters do you mean? Internal or external?
mainly external. Internal, you could do like a sleeve resection, but obviously that has a dramatic impact on the functional outcome in those patients. So I think that you have to be honest to your patients that it has a significant functional impact.
So Dr. Goldenschluger's patient had an external sphincter involvement when he was first diagnosed, but then after TNT, there's incredible downsizing and downstaging, and now it's up above the internal sphincter. It's kind of retreated. And he's adamant to have a reconnection. Dr. Graffalo, what's your choice?
I'm going to go back to Dr. Lavery, and Dr. Lavery was always one to base all of his treatment on the pre-radiation, pre-chemo evaluation. I would have a very lengthy discussion with that patient.
But you know, that was 20 years ago, Dr. Graffalo.
Yeah, exactly. Well, that's why I'm the senior guy around here. That's why I get to remember these old adages.
And TNT didn't exist then.
Yeah, that's true. I think that you're really taking a little bit of a chance if there was definite invasion of the external sphincter or like the puborectalis. If you have definite downsizing, I would have my discussion with these patients when I see this is, look, I'm going to go in with the intent of curing you. And so if I get to that area and there's any question whatsoever, this will be an APR. And I think that, when the patients are very aware that it is, I don't have to have a stoma versus I'm going to have a recurrence, and you make that very clear to them, I think they're very understanding if they wake up and they do have a permanent bag. I'm very cautious about being too aggressive with these patients because, again, when you have to go down there that low, especially if there's been invasion of the external sphincter, you're going to be within the anal canal. Whether you can staple, whether you can do a hand-sewn, even functionally, they're not going to have great outcomes. And that's just, especially after radiation. So I really try to gear the conversation toward a more aggressive and APR type situation in those circumstances.
Fair. Dr. Goldenschluger, what did you guys do?
So, Steve, can you please share this?
Yeah.
Yes. So we went ahead with robotic long-term resection, given the fact that the patient insisted on reconstructive surgery. And we can see here, if you can activate the video, we can see here the dissection in the very low pelvis, very bulky tumor. The patient is obese, so very limited view. And those kind of the major intraoperative challenges I wanted to discuss here with my colleagues. What might be your best techniques for better retraction for those cases, and how do you deal with the smoke that very often obstructs the view in those deep pelvises?
Dr. Chan?
Yeah, this low in the pelvis, one of the first things I do is I change my camera angle 30 up as opposed to 30 down. That helps to kind of look straight onto the canal. The second thing is retracting the prostate up using the tip up to create anterior space. I have really liked using the robotic suction irrigator in my left hand. It helps with dissecting, retracting, which is a lot more gentle than the bipolar is. It also helps with, suctioning and both the smoke and any irrigation fluid. So those have been my go-to.
Dr. Graffalo, any other quick techniques?
I think the big word for this kind of dissection that deep down is patience. It is very difficult to manipulate a bulky tumor in the low pelvis. So for posterior dissection, I usually take the tip up, hook it under the sigmoid colon to elevate it, kind of get that out of the way. I use the bipolar more like a retractor than grasping at all. And so that's the posterior dissection. Anterior can be a little tricky depending on, again, the bulk of the tumor. Again, I take the tip up and I actually kind of grasp and just pull the proximal colon more flat. And then I'll use the bipolar to retract the prostate. A little bit different than what Hanny does, but I think the same idea.
Great. Dr. Goldenschluger, for the sake of time, why don't you just keep presenting your case so we can finish on time?
Yes. So after lengthy dissection, we went all the way down to the pelvis and were able to mobilize the rectum. And here's another question. I don't know if you would like to discuss it. What is our approach to stapling those very low rectal cancers in a narrow pelvis when we actually have challenged to put the stapler down in a very narrow pelvis? And what will be our choice for the colon anastomosis? If we don't have enough,
one word, like what size stapler do you prefer to use when you are really low? Tom?
45.
Honey?
45.
And Anthony?
45, yeah.
Okay, which may require
posterior.
Dr. Liska?
Yeah, definitely 45, but like Tom just said, sometimes you have to do anterior to posterior.
Yeah, and then you might need to fire twice, right, with 45?
Yeah, absolutely. I mean, if you're really low down, then sometimes you get lucky, but in a guy as big as him, you're most likely going to need to.
And also the key is probably to skeletonize everything down to the rectal tube, but even despite that, you might need to use twice. Okay, Dr. Goldenschluger, keep going, please.
Yeah, just to conclude this case, we can move to the next. Postoperative course was quite uneventful. We were able to successfully reverse his ileostomy after 3 months. However, a year after, he was with no evidence of oncologic disease, but he did develop a severe long-term resection syndrome and required a diverting colostomy. I don't know, we have
Okay,
time.
I don't think we're gonna have time for the second one, but maybe just a few minutes here. For low anterior resection syndrome, any tips or tricks to avoid that? Do you have, like surgically at the index operation, any of you think that there is something that we could do differently to minimize the LAR syndrome? I'll start with Tom.
Not to sound too facetious, but I think prayer probably works as good as anything, especially, you know, for the cancer patients. They've been radiated. I would say all of them have some element of LAR. So I think counseling is probably the best thing. I don't know that you can truly do anything to avoid it.
Dr. Chung?
Maybe doing the Baker type side to end, you know, using making a little bit of a colonic pouch. But that's anecdotal. It's not, I haven't been super impressed personally with how that impacts LRs.
Dr. Debak?
No, I agree. And definitely in this obese patients with narrow pelvis, I would do side to end more than a J pouch or colonic J pouch, because I feel that you don't like it. It gets into that smaller space more easily than a pouch. But obviously that usually helps only for the first year, and on the long term, it doesn't make a big difference.
Do you ever do coloplasty?
No, I've never done that. I'm a little bit concerned doing that making a transverse suture. I mean, again, you're supposed not to have any traction and so on, but just by positioning it in the pelvis, I'm a little bit concerned about that, but I've actually never done it.
Do you think with the robotic visualization and 3D hypogastric plexus identification and preserving them would make a difference in terms of reduction in low anterior resection syndrome? Anyone? Dr. Liska?
Yeah, so far the data hasn't shown it. You know, we're still looking for that data. You know, we've been looking for it for a while. So, you know, I think it's so many different factors that go into lungs. You know, besides the nerves, the hypogastric plexus. So you know, there isn't one thing. I do think the colonic J pouch is the one thing that in randomized prospective trials have been shown to help with LARs. And you know, I think yes, most of the effect is early on in the first year. But I think the effect is long term. I think you do have better function long term with the colonic J pouch. That being said, in a patient like this with BMI 40, you're not going to be able to get a colonic J pouch down there. So then doing the Baker type anastomosis is a good idea if you can make it fit nicely and reach nicely. But the data is not as compelling that there isn't good data showing that a Baker makes a big difference as much as a colonic J pouch. So I think if you have skinny female, a colonic J, and you're doing a staple colonal, we know that females also have a higher risk for LARs. I definitely think it's a good idea to think of a J pouch. But in a male pelvis, BMI 40, I think it's not feasible. And the transverse coloplasty, for the randomized controlled trial that we've been doing yet, and the data was not as good with the colonic tract coloplasty. Thanks for joining me, again.
Yeah, sorry, I lost my computer, but I wanted to also mention that the coloplasty, we don't want to give the wrong message. With the coloplasty, as Dr. Debak mentioned, that what is the size limit? I think there's one caveat there that you don't want to make it too big because then late evacuation problems were associated with it. So, Dr. Debak, what is the size limit that you would go with if you're going to do a colonic J pouch?
Oh, for a colonic J pouch, I would do 6-7 centimeters, or I would say I have always to think like 2.5-3 inches, something like that. I think it is. So that's what I would do in terms of size limit. You don't want to make it too large because that will have, as you said, evacuation problems. It also makes it harder to reach as well. So you don't need to make a large pouch, and definitely not as large as an ilioanal pouch.
Yeah, I think even 4 or 5 centimeter. Some studies suggest that it's good enough. We use, especially if you use an 8 centimeter stapler, it becomes always much larger. So it's really harder to make the J pouch smaller colonic J pouch, but it's important to do so. I think this concludes our time, and I really want to deeply thank all the faculty. This was very engaging discussions and conversation, and I learned a lot from these presentations as well. Really appreciate it. And please turn in for the upcoming Cleveland Clinic Live events. Please follow in the website, and they are up and coming. Thank you very much, and have a great evening. And thank you all for joining us this evening.